So to start off with a case stem as usual, we have a 74-year-old Vietnam-era veteran with metastatic esophageal adenocarcinoma who's currently being treated with chemotherapy, listed there. He's brought into the ED by his wife for quote unquote funny behavior times 3 days. The wife explains that the patient has been exhibiting confusion and odd delusions. This morning, he was crying because he believed that he had been drafted for Vietnam. On his first morning of admission, he's found to be pacing in his room, rapidly talking to himself. He demands to leave the hospital, stating, "I'm the head boss of the hospital, so what I say goes." Initial workup, including those listed, are normal. He has no psychiatric history. And what is the most likely diagnosis? Give it a few minutes. So the most likely diagnosis in this case is steroid-induced psychosis. Going through the other options here, for new onset bipolar disorder, this is less likely just given the patient's age and the fact that he has no prior psychiatric history. Oxaliplatin-induced PRES is a phenomenon, although it is exceedingly rare and presents with a slightly different presentation, notably seizures. And brain metastases are less likely given negative CT brain and MRI brain. So steroid-induced psychosis is a diagnosis in the DSM-5, so it has some specific criteria in order to diagnose it. And more broadly, this is actually medication-induced psychosis. But to diagnose it, you need 3 main criteria. Hallucinations or delusions must be present. Other medical causes, including delirium, must be excluded. And the symptoms must cause significant functional impairment so that they can't do their day-to-day activities well. One of the main things I would like you to take away from this talk is that the clinical presentation of steroid-induced psychosis, or more broadly, the adverse mood-related effects from steroids, are a spectrum. So on the most mild end of the spectrum, you have mood changes such as euphoria, distractibility, emotional lability, and lethargy. Moving farther along here, you can get sleep and memory-related deficits, so insomnia, actual anxiety and depression, delirium, and memory loss. That starts to affect people's ability to function day to day. And on the most extreme end of the spectrum, you can get psychosis. Most notably, oftentimes it's manic or hypomanic behavior, full-on bipolar disorder or psychotic disorder. So you can see this, the mood-related adverse effects from steroids can be quite a spectrum. So in terms of clinical features, I want you to remember that this is actually a very common condition. Up to 20% of patients receiving steroids experience some kind of mood-related adverse effect from steroids. About 35% of those patients can exhibit manic or hypomanic behavior, and around another 20% or so can experience psychosis. Steroid-induced psychosis typically will manifest about 3 to 4 days after exposure, but really it can occur at any time, including after cessation of steroids. The symptoms typically linger for a few days after stopping steroids, but it can linger for up to several weeks. So it can be quite debilitating and prolonged. There are certain risk factors that predispose patients to developing steroid-induced psychosis. Most notably, it is a dose and duration dependent phenomenon. So studies have shown that patients taking an equivalent of prednisone 40 milligrams or more are more prone to develop this, and especially if they are taking that high dose for more than 1 week. Females are at slightly higher risk for this condition. In terms of how to manage steroid-induced psychosis, the first cornerstone of treatment is really to discontinue steroids altogether. Oftentimes, this isn't possible if they're taking high-dose steroids to manage some other medical issue. And so it's recommended to try to taper steroids to lower, equivalent or lower if possible of prednisone 40 milligrams per day. If the patient is experiencing psychotic symptoms, low-dose atypical antipsychotics are the drug of choice. The most studied one for this condition is olanzapine, and typically you can start at a low dose of 2.5 milligrams and up titrate from there. Up to around an average or a max of 10 to 15 milligrams per day. For manic symptoms, you can use mood stabilizers. The most commonly studied ones for steroid-induced psychosis have been lithium and valproic acid. Lithium is a little bit tricky because sometimes patients are taking high-dose steroids to manage, autoimmune-related renal issues. SLE comes to mind for renal adverse effects from lupus. But one thing to remember is that carbamazepine should be used with caution because carbamazepine is metabolized by the cytochrome P450 system, which is also the system that metabolizes steroids. For depressive symptoms, SSRIs are the drug of choice. For some reason in the studies that have studied steroid-induced psychosis, TCAs tend to worsen it. So proceed with caution with those medications. So to sum everything up, steroids cause a spectrum of psychiatric disturbances, and this occurs in a dose and duration dependent manner. Steroid-induced psychosis can occur really at any point after exposure to a steroid. To treat steroid-induced psychosis, atypical antipsychotics such as olanzapine, mood stabilizers, and SSRIs may help. But first, try to discontinue or taper steroids if discontinuation is not possible. And just remember that the adverse mood-related effects from steroids occur on a spectrum. Thank you very much.